Bismillahirrahmanirrahim. We start with the lectures on rheumatology, and the first lecture is regarding rheumatoid arthritis. You can say that is the prototype of disease in rheumatology. Rheumatoid arthritis is the most common persistent inflammatory arthritis occurring throughout the world in all ethnic groups, but slightly more common in cold countries, that you can say in temperate countries and subpolar countries of North Europe and North America. It's more common in females. Female to male ratio is 3 to 1. The clinical course is prolonged with the intermittent exacerbations and remissions. The disease is characterized by chronic illness involving mainly the small joints of the hands, the peripheral joints, occasionally large joints, and is characterized by exacerbations and remissions. Now, the patients with rheumatoid arthritis have an increased mortality when they are compared with age-matched controls, primarily due to the cardiovascular disorders. Now, pathophysiology, both genetic and environmental factors appear to be involved in the pathogenesis of rheumatoid arthritis. Rheumatoid arthritis is characterized by infiltration of the synovial membrane with lymphocytes, plasma cells, and macrophages. CD4 T cells play a central role by interacting with other cells in the synovium in the joints. Now, the typical presentation is with pain, joint swelling, and stiffness affecting the small joints of the hands, feet, and wrists. Large joints involvement, systemic symptoms, and extra-articular features may also occur. Examination of the hands often provides a good reflection of the overall disease activity. Uh, the typical features are symmetrical swelling of the metacarpopharyngeal joints and proximal interpharyngeal joints. The classical presentation is involvement of the proximal interpharyngeal joints and metacarpopharyngeal joints. These and other joints are actively inflamed if they are tender on pressure and have stress pain on passive movement or effusion or soft tissue swelling. The characteristic deformities develop with long-standing disease, and that includes swan neck deformity, the buttonhole deformity, buttonhole deformity, and Z deformity of the thumb. Sometimes rheumatoid arthritis has a very acute onset with florid morning stiffness, polyarthritis, and pitting edema. Uh, this more common in this is more common in old age group. Occasionally, the onset is palindromic with relapsing and remitting episodes of pain, stiffness, and swelling which last only for few hours or days. Examination typically reveals the swelling and tenderness of the affected joints. Erythema is unusual and its presence suggests coexistent sepsis. Dorsal subluxation of the ulna at the distal radioulnar joint is common and may contribute to rupture of the fourth and fifth extensor tendons. Triggering of fingers may occur because of nodules in the flexor tendon sheaths. In the foot, dorsal subluxation of the metatarsophalangeal joints may result in cock-up deformities. This causes pain or weight bearing on the exposed metatarsophalangeal heads and development of secondary adventitious bursae and callosities. And this shows the typical deformities of the burnout disease in rheumatoid arthritis. You can see the deformities, a Z deformity of the finger, and you can also see the nodules. This is a ulnar deviation of the fingers, deformity of the thumb. Again, you can see the ulnar deviation and classical deformity of the thumb. Again, a close look. You see involvement of the feet. Again, the deformities affecting the feet. Involvement of the knee joints. Again, another view of the hand deformity. This diagrammatically shows rheumatoid arthritis in a late stage. The Z deformity of the thumb, ulnar deviation of the metacarpophalangeal joints, and swan neck deformity of involvement of the fingers. This shows the swan neck deformity, then Z deformity or buttoneer deformity of the thumb, and ulnar deviation of the fingers at metacarpophalangeal joints. Systemic features are also there. These are anorexia, weight loss, fatigue. They're common and may occur throughout the disease course. Generalized osteoporosis and muscle wasting result from the systemic inflammation. The patient can develop involvement of the bones that leads to the development of osteoporosis and muscle wasting that result in systemic inflammation. Popliteal Baker cysts usually occur in combination with knee synovitis, where synovial fluid communicates with the cyst but is prevented from returning to the joint by valve-like mechanism. Sometimes that ruptures that is induced by knee flexion in the presence of a large effusion that can lead to the severe cough pain and swelling. Now, the criteria for the diagnosis of rheumatoid arthritis. Diagnosis of rheumatoid arthritis is made with four of more of the following. Now, there are certain criteria. If four of them are present, then diagnosis can easily be made. Now, what are those criteria? These are morning stiffness which persists at least more than 1 hour. So, morning stiffness that persists more than 1 hour. Arthritis of three or more than three joint areas. Arthritis of three or more than three joint areas. Arthritis of hand joints. Symmetrical arthritis. Rheumatoid nodules. Rheumatoid factor. And radiological changes. There are seven groups. Out of these seven criteria, four are present. Then one can make the diagnosis of rheumatoid arthritis. And duration of these symptoms should be at least for 6 weeks, more than 6 weeks. There's seven features If four are present, then one can easily diagnose the rheumatoid arthritis. And the criteria is they should be present for at least more than 6 weeks. Now, extra-articular features are more common in patients with long-standing seropositive erosive disease, but may occasionally occur at presentation, especially in men. Most of these features are due to the serositis or granuloma formation or nodule formation or vasculitis. But the main problem in this disease is, of course, vasculitis, and that can involve every organ of the body, and most of the features, that is, extra articular or systemic features, are because of three mechanisms, that is, serositis, granuloma, nodule, or vasculitis. Vasculitis is there in more than 90% of cases, and that is why we call it rheumatoid disease, and we do not call at present rheumatoid arthritis, because it has so many systemic problems. So the better term is rheumatoid disease. The cutaneous and vascular features, rheumatoid nodules occur almost exclusively in seropositive patients, usually at sites of pressure or friction, such as the extensor surfaces of the forearm or sacrum. You can see the nodules at the extensor surface of the forearm because of this pressure areas or friction area, you can say. Now, rheumatoid vasculitis usually occurs in older seropositive patients in the context of systemic symptoms and multiple extra-articular features. So, when the patient has active vasculitis, they are usually positive for the R factor. Vasculitis can vary from relatively benign nail fold infarcts to widespread cutaneous ulceration and skin necrosis. There's involvement of medium-sized arteries that can lead to mesenteric renal or coronary occlusion. The involvement of the medium-sized arteries can lead to mesenteric renal, coronary, or cerebral bleed. So if you see the patient, young patient with CVA, one should rule out SLE and rheumatoid arthritis or other connective tissue disorders. And that is because of the involvement of the cerebral vessels due to vasculitis. Extra-articular manifestation, rheumatoid disease, systemic features, the patient have fever, the non-specific features, fever, weight loss, there's a fatigue, then susceptibility to repeated infections, musculoskeletal involvement that leads to the muscle wasting, tenosynovitis, bursitis, and osteoporosis. Hematological involvement that can lead to anemia, thrombocytosis, eosinophilia, and lymphatic involvement that can lead to Felty syndrome, splenomegaly, nodules formation that can cause sinuses or fissure formation. You can see the involvement of skin because of the vasculitic region on the legs. As I mentioned, this is the extra-articular manifestations are because of vasculitis. This appearance is the skin involvement in the lower extremities due to vasculitis. Again, the vasculitis involving the thumb. Eyes involvement is a number of complications like episcleritis, scleritis, scleromalacia, that is thinning of the sclera, then keratoconjunctivitis. You can see the involvement, this is congestion, scleritis, episcleritis, like a closer view, the congestion of the eyes, but typically redness. This is episcleritis. Again, another view, another view. So you can see the ptosis, that is involvement of the third cranial because of vasculitis. When you see the patient suffering from the isolated palsy of third cranial nerve, when you narrow our diagnosis to medical causes, the most common cause of isolated third nerve palsy, that the medical cause is diabetes. After diabetes, then comes the connective tissue disorders, top on the list, SLE, rheumatoid arthritis. This patient has involvement of third nerve because of vasculitis. This has led to the development of arthrosis of the left eye. See the severe congestion, scleritis, redness of the eyes. These were the, so I repeat, the eye complications. These are episcleritis, scleritis, scleromalacia, keratoconjunctivitis. You can add isolated third nerve palsy, any cranial palsies due to the vasculitis. The vasculitis that can also cause, that can involve the digital arteries, that can cause ulcers, as shown in the figure earlier. It can also cause pyoderma gangrenosum. It can also cause a mononeuritis multiplex. Different nerves are involved at different places. Visceral arthritis that can cause a CV-like picture, infarction, or mesenteric insufficiency. What are the cardiac involvement, or you can say the cardiac manifestations? Rheumatoid arthritis is an important cause of pericarditis. It can cause pericarditis. It can cause myocarditis, endocarditis, conduction defects. The conduction defect occur due to the development of the rheumatoid nodule in the conducting tissue. Conduction defects are because of the development of rheumatoid nodule in the conducting tissue fibers. It can cause coronary vasculitis that can lead to acute myocardial infarction. Then granulomatous aortitis. The aorta is involved in the inflammatory process. Then that can lead to vasculitis, can cause heart block, cardiomyopathy, coronary occlusion, and aortic regurgitation. They all have been reported, but they are rare. The risk of cardiovascular disease is increased due to combination of conventional risk factors such as high cholesterol, smoking, hypertension, reduced physical activity, NSAIDs use of glucocorticoids, and the effects of inflammatory cytokines on vascular endothelium. So they're multifactorial, multiple factors are involved, and they affect all. You can say that they can precipitate the cardiac complication in a patient of rheumatoid arthritis. Now, pulmonary involvement, patient can develop nodules in the lungs. Patient can develop pleural effusions, fibrosing alveolitis, then bronchiolitis, then Capron syndrome. Pulmonary fibrosis may occur, but is often asymptomatic. Now, there is some evidence that the risk of pulmonary fibrosis is increased by anti-TNF therapy, although it's uncertain whether this is a marker of more severe disease in patients who require anti-TNF treatment. Sometimes a patient can come with hoarseness of voice. But this hoarseness of voice is because of cricoarytenoid joint involvement or the development of rheumatoid nodules. Small nodule is formed in the vocal cords. You see the involvement of the lungs. You can see the element of fibrosis, interstitial involvement here, now interstitial lung disease. Here, this patient has developed pleural effusion because of rheumatoid arthritis. Again, pleural effusion as a complication of rheumatoid arthritis. This was a nodule formation. Can you see here nodules? Some mild cardiomegaly also there, and prominent of vascular shadows. The neurological involvement is cervical cone compression because of the subluxation of atlanto-occipital joints. Subluxation of atlanto-occipital joint that can cause compression of the spinal cord, cervical cord. It can lead to quadriparesis. Patient can develop quadriparesis. Then compression neuropathies can also occur, like carpal tunnel syndrome. Peripheral neuropathy is one of the important causes. Rheumatoid arthritis is one of the causes of the peripheral neuropathy. Then mononeuritis multiplex, which means that individual nerves are involved at multiple sites. This showing the X-ray showing the spinal cervical the vertebrae involvement. Amyloidosis is another complication of rheumatoid arthritis. Amyloidosis is a rare complication of long-standing disease that usually presents with nephrotic syndrome. It can also cause microcytic anemia. Microcytic anemia can occur due to iron deficiency resulting from NSAID-induced GIT loss. So most of the patients, we put them on NSAID, and because of chronic use of these anti-inflammatory drugs, there's some bleeding from GIT that leads to the iron deficiency anemia. The Felty syndrome is a rare complication that occurs in seropositive rheumatoid arthritis patients. Splenomegaly, a combination of neutropenia and thrombocytopenia. So combination of rheumatoid arthritis, splenomegaly, neutropenia, and thrombocytopenia is Felty syndrome. Investigations, blood CP, that shows high ESR, C-reactive protein usually raised this shows the acute phase response, but may not be raised in patient with isolated small joint arthritis. Chronic cases may not be increased, but they show the acute phase response. The rise in ESR and CRP. The rheumatoid factors and anti-CCP antibody, that is anticyclic cytokerated peptide antibodies, are detected in 60 to 80% of patients, but their absence does not exclude the diagnosis. If anti-CCP present, diagnose RA, but if they're absent, that does not exclude the diagnosis of rheumatoid arthritis. As far as the RA factor is concerned, uh, RA factors can be positive number of disorders. So if this is positive, that may not be diagnostic. because that is specificity is less, whereas anti-CCV is the most specific test. A positive anti-CCV antibody is highly specific for rheumatoid arthritis and can occur before clinical onset of disease, which means that when the patient develops clinical features, anti-CCV antibodies they appear before these patient develops these features, this feature of the disease, clinical features. Rheumatoid factors is non-specific. Low titers are found in about 10% in normal population, and with the many other diseases like malaria, schistosomiasis, chronic hepatitis, patient can have positive RF factors. So this is not specific for rheumatoid arthritis, whereas anti-CCV antibodies are relatively specific. The plain X-ray of the hands, wrist, and feet are useful. That can show periarticular osteoporosis is common during the early stages of the disease and may be present within 6 months of onset. Then patient can have a non-proliferative marginal joint erosions on X-ray. They're characteristic but uncommon within the first year. You can see this periarticular osteoporosis. You see this here the bone density is less as compared to this. On both sides of joints, bone density is less. This is periarticular osteoporosis. Another view here. Here density is normal, here decrease. Blackish, blackish appearance. Uh, Decrease in the bone density. This shows erosions. And here is the bone displacement. Normal hand, you can compare this with it. You can find erosions here at this point and bone displacement. Again, erosions. You can see the irregularity. This is a ulnar deviation and advanced case of rheumatoid arthritis. Ultrasound and MRI are more sensitive than X-rays at detecting early erosions. Patients who are suspected of having atlantoaxial disease should have lateral X-rays taken in flexion and extension, and the degree of cord compression should be established with MRI. In patients with Baker cyst rupture or without rupture, Doppler ultrasound and an arthrogram may be required to establish the diagnosis. Since a DVT and Baker cyst may coexist, so one has to rule out the presence of D vein thrombosis, which coexists with Baker cyst. We advise for renal function, secondary involvement because of vasculitis of the kidneys, or sometimes the involvement of the kidneys, amyloidosis. So we have to see the renal function and liver function test. What is management of rheumatoid arthritis? First, physical rest, then targeted anti-inflammatory therapy. Passive exercises are the mainstays with the aim of relieving symptoms, suppressing inflammation, and conserving and restoring function in affected joints. So main aim of these exercises are relieving of the symptoms, suppression of the inflammation, and conservation and restoration of the function in the affected joints. A multidisciplinary approach is required, then including the cooperation between doctors, nurses, involvement of physiotherapists, occupational therapists, and the patient education and counseling play and also a key role. And during treatment, periodic assessment of disease activity, progression, and disability is essential. In the vast majority, management is outpatient based, but hospital admission can be helpful in patients with. And what are the patients which require hospital admissions? As very active disease, patients have very active disease requiring bed rest. So patients who are having active disease and they're requiring bed rest. Then if the patient require multiple joint injections, so that cannot be done at home. Patient has to be admitted. So if the patient requires sprinting, then or patient requires regular hydrotherapy, regular physiotherapy. So the or education of the patient. These are the reason for hospitalization. That is very active disease requiring bed rest, multiple joint injections. The patient requires multiple joint injections, splinting, or patient requires regular hydrotherapy, physiotherapy, and for education. First step in the diagnosis, in the drug management is non-steroidal anti-inflammatory drugs. NSAIDs provide some symptomatic relief in rheumatoid arthritis, but do not prevent erosions or alter the disease progression. They do not prevent erosions or alter disease progression. They are not appropriate for monotherapy and should only be used in conjunction with disease modifying antirheumatic drugs. NSAIDs work in arthritis by the same mechanism that causes their side effect. The inhibition COX, the enzyme that converts arachidonic acid to prostaglandins. So they inhibit the enzyme that converts arachidonic acid to prostaglandins. Celecox, a selective COX-2 inhibitor, is FDA approved for the treatment of osteoarthritis and rheumatoid arthritis. Now, as far as NSAIDs are concerned, uh, more than 100 available in the market. And one gain is being manufactured by say, more than 30 companies. But uh, that depends upon the suitability of individual patients. Most commonly used NSAIDs are ibuprofen, mefenamic acid, dicloran, that is diclofenac, Voltaren is trade name, the naproxen, the trade name is Flexin. So there are more than 100 these medicines available, and the patient's suitability of this medicine. Some patients respond to diclofenac sodium, some respond to naproxen. So there is great individual patient variation with the NSAID use. As compared with the traditional NSAID, COX-2 inhibitors are as effective for treating rheumatoid arthritis, but less likely in some circumstances to cause upper GIT tract adverse effects, for example, obstruction, perforation, hemorrhage. Chances of these effects are reduced. Next group of drugs, glucocorticosteroids. Now, low-dose corticosteroids, for example, oral prednisone, 5 to 10 milligram daily, produce a prompt anti-inflammatory effect in rheumatoid arthritis and slow the rate of bone destruction. So in low dose, that slows the rate of bone destruction. However, there are multiple side effects limit their long-term use. Low-dose corticosteroids often are used as a bridge to reduce disease activity until the slow onset disease-modifying antirheumatic drugs take effect, or as adjunctive therapy active disease that persists despite treatment with DMRD. So main use of steroid is to bridge the gap, which means when we put the patient of the disease modifying antibiotic drugs, it takes some time, 3 to 6 months. Want to pass this time, that is utility of steroid. Sometimes with disease modifying agent, symptoms persist. So in that case, steroids are combined with DMARDs, that is disease modifying agents. No more than 10 milligram of prednisone or equivalent per day is appropriate for articular disease. Intra-articular corticosteroids may be helpful if one or two joints are the chief source of difficulty. If one or two joints are the chief source of difficulty, then intra-articular corticosteroids may be helpful. Intra-articular triamcinolone, the 10 to 40 milligram, depending on the size of the joint, to be injected, may be given for symptomatic relief, but not more than 4 times a year. For example, if small joint is involved, we can use 10 milligram. Knee joint is involved, shoulder, we can go up to 40 milligrams. So dose varies between 10 and 40, depending upon the size of the joints, given usually 4 times per year. The synthetic DMARD is methotrexate is usually the initial synthetic DMARD of choice of patients with rheumatoid arthritis. It's generally well tolerated, often produces a beneficial effect in 2 to 6 weeks. The dose is 5 milligram methotrexate once a week. The dose of methotrexate is 7.5 milligram once weekly. If the patient has tolerated methotrexate but has not responded in 1 month, the dose can be 50 milligram orally per week. The maximum dose is 20 to 25. So the usual dose of methotrexate is 7.5 milligram. If the patient can tolerate this dose, we can increase this up to 50 milligram per week. And the maximum dose is 10 to 25 milligram per week. Starting from 7.5 milligram, we can go up to 25 milligram per week. 2.5 milligram tablet, divide into 3 doses. The total dose is up to 25 milligram per week. The most frequent side effects of gastric irritation and stomatitis can cause cytopenias. Hepatotoxicity with fibrosis and cirrhosis is an important toxic effect of the methotrexate, and that should be kept in mind. Methotrexate is contraindicated in patients with any form of chronic hepatitis. If the patient has chronic hepatitis or an evidence of impaired liver function test, the methotrexate is contraindicated. Then next is sulfasalazine. This drug is a second-line agent for rheumatoid arthritis, usually introduced at a dose of 0.5 gram twice daily. That is starting dose, increased each week by 0.5 milligram orally until the patient improves, or the daily dose reaches 3 gram per day. The dose is gradually increased up to 3 gram. Side effects, neutropenia, thrombocytopenia, that occur in 10 to 25% patients and serious in 2 to 5% patients. This is another drug. Then antimalarials, chloroquine phosphate and chloroquine sulfate. Chloroquine phosphate 250 milligram OD and sulfate 200 milligram BD. But keeping in mind the long-term side effects for some involvement of the eyes. Then biological DMARDs, then tumor necrosis factor inhibitors. There are 5 medicines involved in this group, but most commonly used are etanercept, a soluble recombinant TNF receptor, usually administered at a dose of 50 milligrams subcutaneously weekly. The dose is 50 milligram subcutaneously weekly. Then infliximab is dosed 3 to 10 milligram per kg intravenously. Infusions are repeated after 2, 6, 10, and 14 weeks. So initial patient is given the second infusion after 2 weeks, then after 6 weeks, then 10, and then 14 weeks. And then administered every 8 weeks. This is usually usual regime for this medicine. Rheumatoid arthritis in old age, the presentation may be atypical. Or for example, with an initial polymyalgic pain or with synovitis or marked peripheral edema. In young patient, the presentation of RA is classical, but this may not be in old patients. Because in increasing age, the patient have certain other diseases also, like cardiac, renal, GIT disease. Uh, Comorbidity can also make overall management is more difficult in old age patients. Then corticosteroid-induced osteoporosis is more risk is more above the age of 65. The biphosphonate should be co-prescribed in those on corticosteroids. But if you prescribe the steroids patient above the age of 65, that can cause osteoporosis. To prevent the development of osteoporosis, we add biophosphonates. The surgery sometimes recommended synovectomy, wrist or finger tendon sheaths of the hands may be required for pain relief or to prevent tendon rupture when medical interventions have failed. In later stages, when joint damage has occurred, then osteotomy, arthrodesis, or arthroplasty may be required. Rarely done in rheumatoid arthritis. Then rheumatoid arthritis sometimes occurs in pregnancy, or pregnancy occurs in a patient already suffering from rheumatoid arthritis. Immunological changes in pregnancy, many patients with rheumatoid arthritis go into remission during pregnancy. Uh, Methotrexate should be discontinued for at least 3 months and leflunomide discontinued for at least 24 weeks before trying to conceive. The main theoretical risk is immunosuppression in the neonate except for um, sotolizumab, which does cross placenta in negligible amounts. Paracetamol is oral analgesic, the drug of choice in pregnancy. Sometimes NSAID and steroid COX-2 inhibitors can also be used after 20 weeks of gestation. The disease-modifying drugs like sulfasalazine, hydroxychloroquine, azathioprine sometimes can be used to control the active inflammation. Corticosteroids may be used to control the disease flares. The main maternal risks are hypertension, glucose intolerance, and osteoporosis. Methotrexate should be avoided, rather must be avoided. Experience of body therapy is limited, so we cannot comment. So rheumatoid arthritis, we can say, is a prototype of disorder in rheumatology which affects the bone. And just one or two points which I want to repeat. It's a disease which affects the small joints of the hands and characterized by exacerbations like chronic cases. The disease runs in terms of years and primarily involves the small joints of the hands, but sometimes large joints are also involved. It has number of systemic complications that can be cardiac, that can be neurological complications, pulmonary complications, and vasculitis that can involve the skin. So, any question? So my first lecture is rheumatology. My first lecture is this rheumatoid arthritis, and the last lecture again SLE. In between, Professor Lukman and Professor Waheed Usman will take the lectures.